I just want to thank everyone for being here today. I see a lot of our tribal VR folks on that I recognize. And also, there are a lot of state DVR folks on today, too. So I just want to thank you all for joining us as well. Today's presentation is, of course, going to be on the topic of medical and psychosocial aspects of disability. There are so many disabilities. And so what we tried to do is pick out several that are very common in the work that we do with Tribal VR. So today we're just going to cover substance use disorder, depression, and anxiety. And we'll be talking a little bit about what those disorders look like, some of the symptoms of those disorders, what that looks like when we're looking at, some of the limitations or some of the roadblocks to employment that are associated with those particular disabilities. So feel free, if you have any questions, put them in the chat. And then I'm going to try to go through this as quickly as possible. So we may be going through it very quickly, but I want to leave enough time at the end so that we have a good Q&A session so that we can kind of talk about what this looks like in our daily work. A little bit about myself. My name is Jamie Emanuel. Uh-oh. My pages are flipping around on me. Sorry. I'm the training and technical assistance lead at AVERTAC. I'm also a vocational rehabilitation coordinator for our program. My email address is there, so if you have any questions, you're welcome to send me an email or put a direct message in the chat. I'll get that later. I've worked with both state VR in the state of North Carolina and with the state of Arizona as VR counselor in both states before coming over to Tribal VR. My background is in rural VR, and I went to Winston-Salem State University for graduate school.
Yeah, I even brought.
I am a member of the Lumbee tribe of southeastern North Carolina, enrolled member. And the things that I really enjoy working in Tribal VR is the fact that my mother was deaf. I am a CODA, a child of a deaf adult. And that is kind of, I would say, where my passion comes from for working in this field. Today's learning outcomes, we're going to be able to, number one, identify any of the functional limitations of substance use disorder, of depression, and of anxiety. Learning outcome number two, we're going to learn more about what culturally relevant services are, what that looks like, and in the treatment of substance use disorder and in depression and anxiety. And then number three, we're going to talk more about how to plan services and accommodations for these disorders as well. So let's talk a little bit about what some of the definitions or some of these topics that we'll be talking about today in the psychosocial considerations of these disabilities or these disorders. We will be talking about gender, how that affects some individuals and what some of the statistics are related to gender and these disabilities. Also race and ethnicity, culture. Over at Tribal VR, we really implement what we call culturally appropriate services. So you will be hearing us talk today a lot about what culture means in the service provision realm. Family supports, concerns, issues, educational attainment, friends and close relationships, how that interplays into the IPE and some of the service provision. When we talk about, family supports and resources and things like that. Educational attainment, we'll talk a little bit about what some of the roadblocks to educational attainment look like in tribal VR. Again, friends and close relationships, sexuality, spirituality, and any special adjustment issues that are related specifically to a disability diagnosis, for example, grief, loss, depression, anxiety, and then also stigma and discrimination and prejudice that individuals face on a daily basis. Also, we will be talking about functional limitations and loss. Basically, when we define functional limitations, we're saying that these are restrictions that keep individuals from being able to fully perform their activities in their specific occupation. It may even affect their leisurely activities, hobbies, sports, physical exercise, as compared to someone who does not have a disability. So that's when we say functional limitations, that's what we're describing as anything that would prevent an individual from fully performing. When we talk about serious functional limitations, these exist when the individual has a disability related functional related limitation. So the loss that to the extent that substantially we have to provide services or accommodations that are needed to help individuals either prepare for, find, keep, or advance in employment. So that's kind of the difference when we're speaking about functional limitations versus serious functional limitations. Also, we will be discussing functional limitations and loss areas. These are the 7 areas that we mainly look at when we're looking at overcoming limitations or impediments to employment. So these are the areas that we usually note: mobility, work tolerance, communication, self-care, interpersonal skills, cognition and learning, or what some folks describe as self-direction, and also work skills. So I know from my years over in state VR, these were the functional limitations that when we were looking at the eligibility determination, we were describing what those limitations were in these specific areas. Now, in tribal VR, we do not accept someone into the program, unlike over in state VR. Sometimes if they didn't meet criteria in maybe 3 areas or more, you would not have an eligibility determination for services. When we're discussing culturally relevant services, these are services over in tribal VR that reflect the cultural background of the participant. And because we work with so many different tribes, different tribal VR programs, each tribe is different. Each tribe has their own culture, their own belief systems, their own norms, own practices. So when we say we're going to provide culturally relevant services, yes, we are, but those are specific to each tribe and what those services look like for that participant in their tribal connectivity. So these services that we feel are necessary for participants' successful employment, and these are culturally specific services that are unique only to tribal VR agencies. And you'll hear us talk a lot about that. What some of these services look like when we put them in the IPE are things like sweat lodges, smudging, talking circles, prayer, traditional lifestyle, traditional medicine, elder mentoring, cultural classes, social events, and community gatherings. These are all examples of what culturally relevant services are in tribal VR. All right. So now that we've kind of gone through some of these definitions a little bit, let's go ahead and get into the first section of today's presentation. We're going to talk about substance use disorder and what that looks like. So in the definition, when we talk about substance use disorder, basically, it's a cluster of cognitive, behavioral, and psychological symptoms indicating that the individual continues to use substance despite significant substance-related problems. So they can't help it, right? They are addicted, and for whatever reason, both physical and mental, they are unable to discontinue using substances. So what we need to understand is that, important characteristics of substance use disorder is that it makes changes, in brain circuits. And these changes persist in an individual's brain even after they have discontinued the use of substance. And these brain circuits that have been damaged, that are not working correctly, are the reason that these individuals have been diagnosed with a disability. Because even though they may have discontinued the use of whatever substance they may have been addicted to, they have permanently changed the way their brain functions. So overall, the diagnosis of substance use disorder is based on what we call pathological patterns of behaviors that's related to the use of substance occurring within a 12-month period. So to be diagnosed with substance abuse disorder, you have to show these sort of pathological behaviors. And some of the examples of those are impaired control, social impairment, risky use, tolerance, and withdrawal. Some of the common factors of addictive substances, that activation of the brain reward system, right? So once you use the substance, that's the reward to the brain. And some of those joy factors are turned on, and other persistent cognitive behavioral issues. The brain is receiving a reward for receiving that substance. Also, another common factor is like the intense activation of the reward system. So that kind of suspends any kind of normal activities, because what you want to do is get that reward system, right? If you're addicted, this individual is going to want to get that reward system or that brain activation from that reward. So that's going to overcome, and that's going to, for whatever reason, take over normal activities. Also, we need to know that drugs directly activate these reward pathways, and they produce this feeling of pleasure, or what we call high. When the individual does take that substance, they get that euphoric feeling or that good feeling and become what we call high. And it is directly related to the pleasure sensor area in our brain. Also, lower levels of self-control may reflect impairments of brain inhibition. So any of those mechanisms that are related to inhibition, sometimes folks are predisposed to substance use because they do have this impairment, right? And there's not any control over the idea that, hey, this is wrong. It's just that the pleasure from the use of the substance has overtaken any sort of inhibitions that they may have about what is right and what is wrong. So some of the categories in the DSM-5 that we see a lot in tribal VR and in other areas of VR are alcohol-related disorders, cannabis-related disorders, hallucinogenic-related disorders, inhalants, that is very common. Opioid, also very, very common. And then any type of sedative, hypnotic, related disorders, and also stimulant related disorders. These are the common categories, like I said, from the DSM-5 that are substance use disorders and the different areas or the different types of substances. When we say that an individual is in remission or treatment, we describe the early remission to be 3 to 12 months. Sustained remission is considered 12 months or more. If an individual has discontinued use of substances, 3 to 12 months, we feel like they're still very new into their remission or into their sobriety. Anything over 12 months, we feel like it's been sustained, but they are still very, very vulnerable to relapse. Some individuals use maintenance therapy, for example, Suboxone. There are other types of prescription therapy that's used to sustain this sobriety. And it's always in a controlled environment, not always, but most times in a residential treatment environment or what we call inpatient environment. These medications are distributed under a clinical controlled setting, and then usually will begin to be used outside of a controlled setting or a residential setting, and then be considered outpatient treatment. So I'd like to look at these numbers a little bit. I would like for you to take a look at these numbers and look at the rate of substance use disorder as it's broken down into race. And these were all provided to us through the U.S. Mental Health Department. And if you look here on the first line, all of these are NH for non-Hispanic. American Indians or Alaska Natives are number one overall with a 27.6% rate. And we know in tribal VR, this is very common. This is probably one of the most common disabilities that we work with in tribal VR. And I'm sure in other areas of VR, you all are facing probably some of these numbers as well. But it just shows you that the percentages of individuals with substance use disorder are minorities for the most part. And, you know, there's a very high psychosocial factor involved with that. But when I look at this number as a Native American, it's, you know, disparaging to see that my people, my group of people that I associate myself with and identify with are in the highest rate of substance use disorder. And I see it in my community every day. I'm sure you see it in your communities as well. In the past year, we're looking at also some numbers that were provided from the Mental Health Institute on drug use disorder being the highest rate of disability, alcohol use disorder being the second highest, then marijuana, and it goes on down from there. When everything is lumped into drug use disorder, that to me goes right back to the previous list of opioids, stimulants, and other types of drugs that are all lumped into one specific area. But if you look at this number, it states that American Indian and Alaska Native people, this is where they fall into the categories of the types of substance use is used with that population. Also, some of the numbers related to American Indian and Alaska Native adults that either had substance use disorder or any type of other use disorders that are overlapping and what we call codependence or comorbidity. These are 18.6% that with or without what we call serious mental illness. Also, 10.4% overlap with substance abuse disorder and serious mental illness. And then we have 16.3 that do not overlap. So you see that there is a large number, 29%, have substance use disorder that are also suffering from a serious mental illness. So a little bit about potential psychosocial implications related to substance use disorder. An individual will more than likely than not have diminished interpersonal relationships. That's going to look like, their family ties are severed for whatever reason. They do not have a relationship with people that are close to them. Also, an indicator or implication is poverty and homelessness that's related to substance use disorder. Low self-esteem is also another implication from substance use disorder, shame, and then also a dual diagnosis as well. Okay, now here's what we're facing when we are working with individuals with a substance use disorder. These are some of the potential functional limitations that we as counselors are trying to overcome or help this individual overcome. A lot of times they are unable to drive or operate heavy equipment. And for many reasons, right? They don't have a driver's license, can't maintain sobriety, and so therefore they can't take courses to get certified to operate heavy equipment or to drive or driving job duties that are related to their specific job. Also decreased physical health, decreased cognitive ability, their inability to work effectively with coworkers and supervisors, also a decreased capacity to tolerate stress. These are all limitations that are related to substance use disorder. And these are the limitations that we're trying to help individuals overcome. Also, a criminal record, a lot of times, is something that, is going to be very common for someone that has substance use disorder disability. And they're trying to overcome these particular functional limitations that are related to their disability. So when we see those types of limitations, we know that there may have to be some accommodations related to those limitations, correct? So when we're writing the IPE and we're trying to put services in place, we may have to look at some things to overcome some of these roadblocks to employment. For example, electronic organizer. A lot of times now, I believe everybody just about has a cell phone nowadays. Even children that I see out in public have a cell phone. And sometimes we can load these electronic organizers or download, an app or something like that onto a cell phone to help individuals keep themselves organized based on, what we talked about earlier as far as some of those brain circuits that are not working correctly anymore. And they need some help with keeping themselves organized. That could be anything like a calendar, calendar reminders, or what we call a tickler or something like that. Also, another accommodation may be a flexible schedule or a modified break schedule on the job. When we are working with job placement, a lot of times we may have to do some job carving or make some accommodations available to the individual if that is their desire to do so. If they decide to relate their disability needs to their employer. Also, sometimes written instructions are a good thing to use. I know myself personally, I like to have things in writing because I'm one of those types of people that likes to check things off of my list. And so sometimes you can tell me what you want to tell me, but go ahead and put that in writing because I'd like to have something in writing in front of me. Also recorded directives, messages, materials. Sometimes individuals work better with a recorded message that tells them exactly what to do or how to do things. And then like myself, I like a checklist. So these are some just routine accommodations that we look at when we're looking at individuals or working with individuals with substance use disorders. And these are just some very common and easily obtained accommodations. So I have some questions here, but I'm going to go ahead and move on into the next section of the presentation. But if you kind of look over these questions here about substance use disorder, what are some culturally relevant services? You may want to jot this down because we're going to talk about this in the Q&A at the end. When you are working with individuals with substance use disorder, what are some culturally relevant services that you may have provided to an individual or that you may consider to work with someone that has substance use disorder? And also, what are some accommodations that you may have provided or you could possibly provide to a participant with a substance use disorder? We'll talk about that a little bit later. Now I'd like to talk a little bit. First of all, were there any questions about the first section, substance use disorder? Does anybody have any questions they want to ask real quickly? Okay, we'll go on to the next section on depression, or what we call major depression disorder or persistent depression disorder. Depression, blah, I can't talk. Persistent depressive disorder. Those are two separate diagnoses. So let's talk a little bit about the statistics related to depression and American Indians, Alaska Natives. Most American Indian or Alaska Native adults report experience serious psychological distress 2.5 times more than the general population over a month's time. Also, these studies have reported that 8.9% of American Indians and Alaska Native adults experience a major depressive disorder or episode higher than any other ethnicity except those with multiple ethnic identities, so mixed race. And also the suicide death rate for American Indians and Alaska Native youth aged 15 to 19 is more than double that of any non-Hispanic whites. So, this is a sad statistic, but it's one that we face every day in our rural communities, on the reservations, and in our Indian communities. A major depressive disorder is basically the essential feature is a period of at least 2 weeks or more during which there's either a depressed mood or the loss of interest or pleasure in nearly all activities with at least 4 of the 7 additional symptoms that we talked about earlier. The symptoms may cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, and are frequently co-occur with substance-related disorders, panic disorders, obsessive compulsive disorder, anorexia nervosa, bulimia nervosa, and borderline personality disorder. So depression, we look at individuals with these other disorders and see that they co-occur the majority of the time. And to look at some of this major depressive disorder prevalence, if you look at this graph, you will see that overall, the age group 18 to 25 is the highest age group, and the race is 11.2% American Indians, Alaska Natives, and 13.9% in 2 or more mixed race ethnicities. So again, we're looking at the youngest group of females in minority or race ethnicity populations. You know, that's a sad number to look at. To see this high level of depression disorder amongst this age group, this gender, and in these minority groups. When we're looking at major depressive disorder severity, over the past year, with depression symptoms or depressive episodes in the US, we are looking at, with severe impairment, 64%, without severe impairment, 36%. So the largest majority here, you can see, also not only have a severe impairment, but it is of the most severe. The difference in that and persistent depressive disorder is that the essential feature is a depressed mood that occurs for most of the day, for more days than not, for at least 2 years. And this is the most severe type of depressive disorder. So during that 2-year period, any symptom-free intervals, they don't last any longer than 2 months. And during that period of depressed mood, at least 2 of the 6 symptoms that we discussed earlier are present. And these individuals are at a higher risk for psychiatric comorbidity in general, and for anxiety disorders, substance use disorders in particular. So we're looking at, again, these co-occurring disabilities with either substance use disorder or an anxiety disorder that are happening with the most severe depressive disorder. And looking over the past year, the severity of depressive, or what we call severe depressive disorder, among U.S. adults, you can see here that the most serious are 49.7%, moderate is 32.1, and then mild 18.2. So again, the comorbidity rates are the highest among individuals that have the most severe symptoms of depressive disorder. And so here are some of the potential psychosocial implications that are related to this disorder. Individuals will usually have more pain and physical illness. They'll have a greater decrease in physical, social, and role functioning. So they are not functioning as near or close to what we call normal functioning physically due to pain or any other type of physical illness. Also, a loss of interest and participation in social activities. Individuals are not getting out and not participating in social activities in their community, with their families, with their friends. You just see a great decrease in these type of activities. Also, insomnia or what we call hypersomnia. Either individuals cannot sleep at all and are not getting rest, or sleep all the time, and I've seen this with individuals that I have worked with before. Their sleep patterns suffer greatly. Also, the risk of suicide and self-harm are very high in this group. So these are some of the psychosocial implications that we may be looking at when we're working with these type individuals. Some of the functional limitations related to this disorder are decreased energy levels, impaired cognition, so like concentration, memory, decision making, trying to remember things. It's severely impaired. Also, stress intolerance is a big thing with individuals that suffer from depression. You'll see this, people that cannot control their anger or they lash out. And a lot of times that is directly related to being depressed. Also, decreased motivation for work activities. For whatever reason, there's no satisfaction for completing work activities. And so, therefore, there's just no motivation there. Also, absenteeism is a really big problem with individuals who suffer from major depressive disorder because of the sleep patterns that we were just talking about. If you're not getting enough sleep, you're just not going to be able to get up and go to work. Or if you're sleeping all the time, you still are not having the ability to get up and go to your job every day. Some potential accommodations related to this disability are, again, a flexible work schedule. So if someone is suffering from major depressive disorder and they're not able to sleep, and they're not able to get up at a certain time and go to their job, if the accommodation is available to them to work a different shift to kind of offset those sleep patterns, maybe that's something that you can look at when you're writing up a particular IPE and putting some of these accommodations in place. Also, modified or extended breaks to, possibly overcome some of these limitations. A reduction of workload during active stages of depression. So depression, it's cyclical. It's, comes in cycles. It sometimes, and with other disorders besides depression, you'll have individuals that have, a month of really great medication relief for their symptoms, but then they may return back to those symptoms again. So it goes in cycles. So sometimes those workloads can be adjusted somewhat during that active stage of depression. And again, we talked about electronic organizers. This is something that I talk about a lot, is simulated skylights or windows or full spectrum lighting. The sun is so important to us individuals. We need the sun. We need that vitamin D or vitamin whatever we're getting from the sun, and it helps stimulate us. And so having some sort of, I've heard of individuals ordering what they call sun simulation lights or light bulbs that you can actually replicate, sunlight, not to get burnt from it, but to give you that stimulation that you need from the light. And also, if it's possible to provide telework or remote work during these active stages of depression, those are some of the accommodations that you may consider. And again, if you want to jot these questions down, we're going to talk a little bit about what culturally relevant services are related to depression. If you have provided any of these type culturally related services, I'd like to ask individuals to talk a little bit about that and what that looks like, and what are some accommodations that you may have provided an individual on the job to overcome these major depressive disorder symptoms. Any questions about depression disorder? Does anybody have any questions they want to ask quickly? Or we'll move on. I see a lot of chats up there, Earlson.
Yeah, we saw. I have two of them from Tammy, but they're related to the questions we're going to talk about.
Okay, all right.
And then
Right.
just mentioned that she has a therapy lamp on her desk that she uses while she's at work.
Oh, that's great. I've heard of those. Okay, let's move on to anxiety disorder, or what we call panic disorder or generalized anxiety disorder. So anxiety disorders include disorders that share features of excessive fear and anxiety and related behavioral disturbances. So for example, fear is the emotional response to real or perceived imminent threat, often associated with surges of atomic arousal necessary for fight or flight, and thoughts of immediate danger and escape behaviors. So that's fear, right? That's that I got to get out of this situation. I've got to move my feet and get away from here. That's fear. Anxiety, on the other hand, is anticipation of future threats, often associated with muscle tension, vigilance in preparation for future danger, and cautious or avoidant behaviors. So fear is that emotional response of something that's happening right now. I've got to get away from this thing right now. Anxiety, on the other hand, is the thought of any danger that you may face, or the thought of, any future danger, or what, the what ifs is what I call them. And that fear of anything that could possibly happen. So that is what when we're talking about anxiety disorders, we're talking about fear, real fear, and then also anxiety related to perceived or future danger. A panic disorder is when a recurrent or unexpected panic attack, which are very abrupt surges of intense fear or intense discomfort that reaches a peak within minutes and includes at least 4 of the 13 physical and cognitive symptoms listed in the DSM-5 TR. So at least one of the attacks has been followed by 1 month or more of one or both of the following symptoms. Number 1, persistent concerns or worry about additional panic attacks or their consequences. And number 2, a significant maladaptive change in behavior related to the attack. So, usually an individual that suffers from panic attacks, sometimes it'll just come on them all of a sudden out of nowhere, right? And they just can't control it. That panic just overcomes them out of the blue, and they don't understand why. We often see individuals who have this panic disorder. They'll change their behavior, right? I've heard of people, they quit drinking caffeine because they think caffeine's going to stimulate them into having a panic disorder, or a panic attack. I'm sorry. Sometimes folks that are afraid of elevators, are not going to, because they're claustrophobic. They're not going to get in that enclosed elevator. They'll walk 10 flights of steps to not have to get in that elevator. So they've changed their behavior, because they're afraid of the possibility of having a panic attack. So let's look at some of the numbers related to panic disorder. In the U.S., the general population, a 12-month prevalence estimate is about 2 to 3% of the adults and adolescents in the United States have this disorder. American Indians, Alaska Native individuals have a significantly higher rate of panic disorder than any other ethnic group in the U.S., and that's ranging from 2.6 to 4.1%. And we could talk a whole lot more just specifically about the perceived reasons for this higher rate of this disorder in this particular ethnic group. Personally, I feel that, it's related to trauma, some current trauma, and then also previous trauma, or what we call generational trauma. Females are more frequently affected than males at a rate of approximately 2 to 1. Panic disorder severity. So over the past year, the severity of panic disorders among U.S. adults, the rate is serious at 44.8%, moderate at 29.5%, and mild at 25.7%. So almost, not quite half of the individuals with panic disorder in the United States have what we call severe anxiety disorder or panic disorder. The comorbidity or the co-occurring prevalence of panic disorder is elevated in individuals with other disorders, particularly if they have an anxiety disorder, a major depressive disorder, bipolar disorder, or an alcohol use disorder. So a lot of times you're going to see this panic disorder is going to co-occur with individuals that have these other type disabilities as well. A subset of individuals with panic disorder develop a substance-related disorder, which for some represents self-medication attempts. And I have witnessed that with individuals that I have worked with personally. They're just trying to self-medicate. For whatever reason, they do not have insurance, so they're not being able to be treated or have any type of treatment plan, and they're just trying to cope with the symptoms of this disorder. And sometimes that looks like substance use disorder because they're using whatever substance that they can attain on the streets or privately, just to try to maintain a semblance of normalcy when dealing with this disorder. Also, panic disorder is significantly comorbid with numerous general medical symptoms and conditions that includes dizziness, cardiac arrhythmias, hyperthyroidism, asthma, COPD, and irritable bowel syndrome. So a lot of times you'll see these symptoms an individual may have. Have heard individuals report that they get tingling in their fingers, in their extremities, will get like a tingling sensation. And I think that's related to their heart functioning. But you will see a lot of these different types of symptoms with individuals that have this panic disorder. Let's talk a little bit about what generalized anxiety disorder looks like. So the essential feature is that it's excessive anxiety and worry occurring more days than not for at least 6 months. The symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Also, the anxiety or worry is associated with at least 3 to 6 of those symptoms. Individuals with generalized anxiety disorder are likely to have met criteria for other types of anxiety or what we call unipolar depressive disorders. So this generalized anxiety disorder is usually you'll see it diagnosed more than the panic disorder, but a lot of times the panic attacks will come from this overall generalized anxiety disorder. So the numbers related to generalized anxiety disorder over 12-month prevalence is about 0.9% among adolescents and 2.9% among adults in the general population of the United States. Females are twice as likely as males to experience generalized anxiety disorder, and the prevalence of the diagnosis peaks in middle age and declines across the later years of life. I've wondered about that number. Like, why is it that it usually is diagnosed in younger ages? And then people sometimes, I don't know if they just learn how to deal with it or if they have received treatment, but usually it declines in later years of life. And so in the US, the higher prevalence is associated with exposure to racism and ethnic discrimination. And again, looking at the severity of generalized anxiety disorder, individuals were surveyed over the past year. The severity of the disorder was 32.3% serious, 44.6% moderate, and 23.1% mild. So in this particular area, the generalized anxiety disorder, it's actually the numbers are higher for the moderate severity of the symptoms. Some of the psychosocial implications related to this disorder are decreased social and occupational activities, considerable economic costs, mostly stemming from high levels of medical visits. People think they're having a heart attack, so they have to go to the ER to try to treat the symptoms. Also, significant behavior or changes in behavior related to perceived threats. So what we may think ourselves, as being, oh, that's ridiculous. You're afraid of elevators. It's a perceived threat. And to that individual, that threat is real. They're going to get in that elevator, the door's going to close, and they're trapped. And so their perception of the threat is totally different than what our perception of a threat may be. Also, avoidance of certain situations or environments. Again, if someone has a perceived threat, I worked with an individual one time who could not cross the railroad tracks in their town because their house was on one side of the railroad track. And if they cross the railroad track to go to the store, they may not be able to get back to their house. And that's just a perceived threat. A train may come, block the railroad, and they cannot get home. And so this is just an avoidance situation where there was a perceived threat. The individual was, for whatever reason, was not crossing that railroad track. And, in that person's mind, it was a real threat. So that avoidance is a very big, implication from this disorder. Individuals are going to avoid perceived threats, even though it may not seem rational to you or I, or someone that's not suffering from this disorder. For that individual, it is a rational perceived threat, and they are going to avoid it at all costs. Functional limitations potentially associated with this disorder are muscle tension. There may be trembling, twitching, feeling shaky, muscle aches, or soreness. An individual with generalized anxiety disorder also may experience other symptoms such as sweating, nausea, diarrhea, and other exaggerated what we call startle responses. Excessive worrying impairs the individual's capability or capacity to do things quickly and efficiently, whether they're at home or whether they're at work. And also a high number of missed days of work are associated with this particular disorder. Some potential accommodations that may be related to this disorder. You may consider when you're writing the IPE and trying to look at the impairments and impediments to employment. A flexible work schedule, again, may be helpful for this individual. Modified or extended breaks in case, they're going to need some time to recover from an episode. A private space at work or place where they may could go lay down or have some quiet time to themselves. Sometimes a support animal is very helpful with this particular disorder. You see sometimes what they describe as an emotional support pet or emotional support animal. And for this individual, this is a way to gain relief from the symptoms of the disorder. Also, identification and reduction of triggers is also very helpful. If you can identify or help this individual identify what's triggering the panic disorder, if an individual is afraid, again, of the elevator, then what can we do to reduce the stress related to elevators? We find an alternate route, the stairwell or some other way to reach what a different building that has the same setup, that doesn't have an elevator. Those types of things are what we can look at when we're identifying and reducing some of those triggers. And so again, we're going to talk about in our large group discussion, we're going to get started here in a minute with our Q&A about what culturally relevant services are associated with individuals with an anxiety disorder, and maybe some accommodations that you may have provided to a participant with this particular anxiety disorder. So I'm going to stop sharing my screen. And let's get into it. Let's talk about it a little bit. Let's go back to depression. Would anyone like to talk a little bit about what culturally relevant services, or maybe just in particular, just specific services that you may have put in place for an individual that suffers from substance use disorder. Let's talk about that first. Do I have any volunteers? Come on, now's the time. I've been talking all this time. Now's the time for you all to chime in.
Can you hear me?
I can hear you, Sheila. Yes.
Hey, thank you for doing this today. It really helped a lot to refresh some of my memory. But one of the things that we do with our substance abuse people, we always recommend that they go to Allen Anishki, which is our behavioral health. And with that program, they offer MAT classes, SAT classes, and they've also started offering culturally appropriate classes. And they also I also recommend that, we live close to the water. Going down to the water is such a healing thing. Even if you don't fish or anything, just sitting there by the water has been really helpful for a lot of my clients. That's just a couple of suggestions from me.
Thank you so much, Sheila. Yes, I agree. Working with your tribal services, some of your cultural services with your tribe, that's an excellent way to help individuals overcome some of these. Just being able to talk to someone who shares your same culture, your same belief systems, and understands where you're coming from, or possibly speaking your own specific language. Those are all things that I feel like you're doing exactly right. And I'm glad to hear about the water thing, because I thought I was the only one that thought water was calming. I love water. Anyone else? Anyone from State VR would like to talk a little bit about some services you may put in place to help individuals overcome some of the symptoms of substance use disorder? So me personally, as a counselor, I would want to see that this individual is receiving diagnosis and treatment services, so that we know that they are in treatment, have received a treatment plan, so that they will not have the likelihood of relapsing. Depending on, what we talked about earlier, anything less than 12 months is considered a short-term sobriety. So having that help on hand, I feel like, is going to help those individuals make sure that they have someone to talk to and may possibly have the medications that they need to continue their sobriety. Anybody else think kind of along those lines? Okay.
So, oh,
Go ahead, Gary. Yes.
So a lot of the folks around here don't necessarily think that we have the ability to get them assessed. So that's always something new. I always tell them, hey, you know what, we can get you assessed. A lot of the folks that do struggle with the co-occurring disorders don't necessarily want to reach out for help. They you know, and I've actually been one of those folks, right? So the last thing I want to admit is that I need help. So what I do is, if I know clearly from observation that they're struggling with it, I'll definitely, hey, you know, what's going on? You get to know them, build that rapport. I walk up to them, you know, just because they have that wall, so to speak, that boundary there. I always try to, you know, not necessarily go over there and target the issue, but I try to build that rapport first. And I'm always most likely in a social setting as opposed to, hey, let's go into my office right away. You know what I'm saying? So I try to buffer that initial interaction, and I try to let them know that, hey, you know what, I'm human too. You know, I always try to relate with them, and but also, you know, a sense of humor and just having that empathy is just like a great way to get folks into the doors. Because when I started my recovery, it took that one case manager to put me under her wing and go above and beyond for me. She didn't have to, nor was I her client, but you know, just making that connection in the community is phenomenal, and it's definitely a really, really great start to somebody who's feeling down in the dumps.
Oh, thanks so much, Carrie. Absolutely. The first thing and we talk about this all the time in Tribal VR, right? Is that relationship building, like that trust factor. When we look at generational trauma, and how much more prevalent it is for Tribal VR consumers. I love how you just said, you know, hey, I'm human too. Let's just talk. Let's start building this relationship and start building this trust. And I think that's so important when we're working with individuals that suffer from this particular disorder. Um, you know, and not saying that individuals outside of Tribal VR don't suffer the same severity or symptoms, but you know, there's just so many factors related to culturally relevant services that I feel like are very important. And I'm not sure if Dr. Gashioma would like to talk a little bit about cultural relevance in the provision of Tribal VR services, but I sure would like to hear what he has to say.
Good morning, good afternoon, everyone. First of all, I'd like to share as a reminder that in most of the American Indian communities or Indian country in general do not have a specific word for disability. So it's important to determine whether or not a tribal consumer or participant does does have a lifestyle that incorporates traditional environment, and whether or not the individual does use traditional healing services, and if that resource is available to include that service as a part of the IPE, but also recognizing that the treatment by traditional healers may be a very confidential situation where we don't necessarily require that perhaps the case note provide detailed information regarding the treatment itself. We like to think that in the tribal communities that this service provision is between the traditional healer and the participant. And it may be that the information for the treatment itself should not be recorded in the case note. Also, recognizing that some of the tribal programs in Indian country do have qualified individuals that can discuss and develop a plan to address the intergenerational trauma, the historical trauma, making sure that they do have a good knowledge of what that entails. I'm always of the opinion that we don't go into a service or treatment area that we're not qualified to provide, and also make sure that there's a safety net for our tribal consumers or participants in the event that the situation is more than we can possibly handle.
Thank you, Dr. Gashioma. Appreciate that input. And you're so right on so many points that you brought up. And those are what we're facing, in tribal VR.